Today, our first lecture, we're going to talk about blood donations. At this point, a lot of you have gone through the process. Those of you guys that have done it so far, how many of you was it your first time donating? Just a couple, okay. My hope is that you kind of realize, well, that wasn't so bad. And, you know, whenever your work offers a blood drive or you have an opportunity to do one, that you'll be like, oh yeah, I could do that. That wasn't so awful. I also, part of the reason I assigned that assignment is I think it's important for you guys to see that piece of it. Because when you're in the lab with this cooler full of blood, this fridge full of blood, those all came from somebody. And I always think that's important to remember. You know, it's not something that we just manufacture and it magically shows up in our refrigerator. I think that's one of the reasons blood bankers, you know, we take blood bank very seriously because we have this product that somebody donated and we're giving it to somebody else. And so there's a lot of people involved in both sides of it. So in today's lecture, we're going to talk about blood requirements, donation process, donor testing, and autologous and directed donations. Now, yeah.
Sorry, we don't have anything in our notes about this, right? Or do we?
Yeah, there's a chapter.
Which chapter?
17.
Oh, I see.
Okay, it should be there. Now, I'm going to start this lecture with a disclaimer. The process for blood donation is always changing. The rules are always changing. As our tests have gotten better, some of the deferral periods have become a lot less. Some of them have changed completely. So, as we're going through this, know that I like pointing out things you have to know, but then some of them are things like these are the last guidelines that I saw. And actually, I just now looked something up and I saw a new guideline. I'm like, oh shoot, I didn't update that one. But know that it is always changing, and the best place to go, we'll talk about when you're going to do your homework, is redcross.org. They have all the current requirements right there. But there's a few things that are like board type questions that you have to know, and we'll make sure to hit those questions. So general requirements, 8 weeks since the last donation. 8 weeks, 56 days. That's a number you need to know. That's what.
Does that count for platelet donations?
Hmm?
Does that count for platelet donations as well?
No. Platelets, it's 1 week. Yep, that's a good question. Platelets is 1 week.
They just called me. I think it's 3 days now.
Is it done with 3 days now? Because
Yeah,
I just looked online, it said 1 week, because it used to be 3 days.
Okay, maybe they just.
Maybe if they have you matched with somebody, because it used to be 3 days, and then I just saw online that it's a week. But maybe because if they have you matched, are you being called in specifically for something?
I know they called me. I don't know if it was me specifically.
So I used to have problems donating platelets because I react to the sodium citrate. It binds the calcium in my body, and my muscles start contracting. Like I'll be sitting there literally, and you can like I start contracting in. I had a phenomenal nurse that worked with me, and she was able to do, you know, we took care of each other. She put me on a heated blanket with a hot pad on my chest and a heated blanket over me. I mean, this is what it took for me to donate platelets. But when they had me matched, especially with kids, something about my platelets, I guess, they sent to the kids. So of course I went in, because it was for a kid, you know, I'm not gonna say, sorry kid. But yeah, so it might be only 3 days now. I mean, it's one of those things that is constantly changing. If they call you, great, go in. This is just for red cells though. For red cell donations, 8 weeks, 56 days. Very important numbers to remember. At least 1 year since your last transfusion. Actually, I just looked that up, 3 months now. That's just been changed to 3 months. Used to be a full year since a transfusion. If you got a transfusion less than 3 months ago though, chances are really good you're dealing with some medical problem and you probably shouldn't be giving up your blood, or you dealt with a major trauma and you're still healing from it, but that number is now 3 months. Yeah.
I'm assuming you want us to know these numbers and not different numbers.
So I'm telling you this, when you're gonna be looking those numbers up line. This you have to know. This we can talk about being 3 months now. Just know it's constantly changing. Because we can update more. We can actually, it's faster testing. At least 6 weeks following pregnancy, because you know pregnancy is hard on the body and does a lot, and they don't want you when you're pregnant donating, or for 6 weeks after. And even that, you want to make sure you're healthy enough. One of the things is you have to be generally healthy to donate. So depending on, some people are super healthy at 6 weeks post-pregnancy. Some of us are just dragging our butts out of bed at 6 months after pregnancy, or 6 weeks after pregnancy. So it just depends on you as a person, but at least 6 weeks. No recent dental work. The reason is when they do dental work, we get bacteria into our bloodstream, and we don't want those bacteria going to somebody that might be immunosuppressed or have other issues. So like, they don't want cleanings within a couple weeks usually. You know, they'll ask, have you had any recent dental work? What have you had done? No recent tattoos or ear piercings if unregulated or sterility is questioned. So if you go to your bathroom at home and you and your 17-year-old friend are piercing your ears, you're now deferred for 3 months, okay? If you go to some place like a piercing lounge who has sterile criteria, they're licensed in Wisconsin, you're fine, you can donate right away. Claire's, where they use single-use, those gun thing, it's all single-use and disposable, then you're good to go.
Clean.
Huh?
Those single-use things, those are not clean.
But they're disposed of now.
Like the whole thing.
The whole thing gets
Really?
disposed of now. Mhm.
Oh, that's-
So, yeah. So, tattoos, believe it or not, some states don't regulate tattoos. If you are traveling and decide to get a tattoo with your buddies you're traveling with, please know if that state requires licensing or not. If it requires licensing, you have to prove sterility and that you have to make sure your autoclave works and all that fun stuff. I still find it amazing with the things they do mandate and license that tattoo institutions are not licensed in all states. I always laugh this last one, risk-free lifestyle. And what they're really talking about is sexually transmitted infections more than anything. Travel history, this is always changing too. And a lot of times, like actually what the website says right now, any travel history in the last 3 years you bring with you so they can look it up at that moment in time. Because you might have been in a certain area that is normally okay, but for 3 months last year, it was endemic in malaria or something. It's really weird. So any prolonged travel to Western Europe, they worry about CJD, Creutzfeldt-Jakob disease. Malarial endemic countries, I don't even know what the rules are right now for that, but it was about 12 months after a visit, 3 years after living there. So if I were to move to the equator and live there, I'm deferred for 3 years. When I was in Tanzania for 3 months, I was actually deferred for other reasons, but I would have probably, because I lived there for 3 months and didn't actually just visit for a couple weeks, I probably would have been deferred for 3 years. So that's important for them to know because they will get deeper, they'll do a deeper dive into all travel once you're there. Iraq, we were about leishmaniasis. So anybody that travels to like Iraq, for example, like military, they are restricted from donating through the Red Cross for 12 months because of the leishmaniasis that's common. So good general health, no history of heart, liver, or lung disease. Because if you have a history of a heart disease, for example, and we start taking blood, it's going to affect things, so they don't want you having a problem while you're donating. No history of cancer, but it depends on the type of cancer. That's changed. That was another one I just looked up. I'm going to have to really change this lecture. A lot has changed in the last year since I did this last. Hepatitis or AIDS, if you've ever tested positive for hepatitis B or C, or any HIV, you're permanently deferred for those. They went through a period of time where if you've ever been jaundiced, you started getting deferred. Well, you guys haven't quite gotten to chemistry yet, but there's a lot of reasons you could be jaundiced. Epstein-Barr virus causes jaundice in about 15% of the population. I was one of those, and so that's how I had gotten deferred for like 15 years. I was deferred from donating because I had jaundice. They fixed that now. Now it's specifically if you have ever tested positive for hepatitis B or hepatitis C. Physical requirements, at least 110 pounds, at least 17 years old in Wisconsin, maximum oral temperature 37.5, so you can't be running a fever, because if you're running a fever, there's a really good chance your blood's got bacteria in it. Maximum blood pressure, 180/100. Seems really high, but that's what they call as their maximum. Pulse, 50 to 100 in regular. They will accept trained athletes. There are some trained, like high athlete high ability athletes whose pulses run in the 40s. So if it is less than 50, they'll have to have the medical doctor come out and decide, is it because you're a regular marathon runner? Or is it because you have a heart problem that we need to send you to the ER now? You know, what's going on? Hematocrit, minimum hematocrit is 38. They actually use these little hemocubes to do it. They used to use the falling drop method. This was actually really cool. It was copper sulfate, and they draw blood, and they count how long it took to drop. If it took too long to drop, you were anemic and couldn't donate. And then you'd go sit at the counter, and this would be sitting there with all these little drops of blood at the bottom of it. It was the craziest thing. It was really crazy. Now we have hemocubes. You gotta remember, these things aren't that old. Or another rapid method. So, pre-donor process. They have an app now. Of course they do, right? There's an app for that. There's an app for everything. But pretty much, they want to make sure you're well hydrated before you go. Because that's one of the biggest problems we have. And you guys even noticed that probably with phlebotomy. You did better if you had a light breakfast and stayed hydrated those first couple times that you were doing phlebotomy. Same idea here, stay hydrated. A light meal, and then you get all this educational material to read. Now it's all in an app. You read the page, next, and you kind of go through the whole process. It used to be a piece of paper like this. They probably still have the paper for people who don't have the app. Like, you know, there's a lot of older people that donate that aren't as good with phones. So they complete this health history questionnaire. Back in the day, it was like this. Now it's all on the computer. It's all in your app, actually. You go through and answer all these questions. And the questions are always updating and changing depending on what's happening, what's going on. So you finish the app, and it says, okay, now you're set to go. And then you get in this little room, and a nurse is going to take your vitals. They inspect your donor arm for scars, lesions, anything that might make it more difficult. They want to look at your vein. Is it a good vein? Are they going to have trouble with it? They do a 30-second iodine soap scrub. And actually, if I'm not mistaken, anybody that had it done, do they use iodine or are they using chlorhexidine now? They are now, right? Okay. That was a more recent change, switching over to the chlorhexidine props. They still used iodine a few years ago. And I was like, why are we using iodine? Because, you know, the research was out there for chlorhexidine, so now they're actually, that's good to know. I'll have to update this. I'll update this entire PowerPoint. Probably just wipe it out and start again. They place a blood pressure cuff on the arm, and they inflate it to 40 millimeters of mercury. So what that means is it's just really, really light. It's not a full tourniquet, but it's just enough of a tourniquet to kind of help collect the blood. There's a 16-gauge needle. What size do we use when we're doing phlebotomy in general? 21. 21. 16 is huge, right? Did you guys look at it before it went in?
Yeah. Couldn't stop staring at it.
It looks like a sink pipe coming at you. Yeah, it's a big needle. Because, think about it though, they're going to take this blood and they want it to be good for a chunk of time, right? They want it to be good for a couple months. And if they use too small of a needle, automatically some of those cells lyse coming through.
Also, it would probably take like a really long time.
Yeah, if you went to a 21, it would take a long time. Yes, that's another reason. Ideal donation is 6 to 8 minutes. If it takes 15 minutes or more, they'll stop it and probably throw away the collection, because at 15 minutes, we start getting more potential for clots forming in the bags. What they do is when they're donating it, you'll see them come over and they'll pick up the bag a couple times during donation. They pick it up and they flip it a couple times and put it back down, and that's just to make sure the anticoagulant is actually getting mixed in it really well. If they just let it there and let it mix as it's falling in, you're going to have clotting, so you want to make sure to avoid that. Most of them have these full bag triggers now, where as soon as it's full, it triggers kind of like a shut off, and it alerts the nurse that the bag is full. It's the full weight. So they collect about 500 cc's of whole blood with anticoagulant in it. That's what they're collecting in the bag. When they're doing this, you're going to see, so they have this IV tubing, it's collecting in this bag. They're going to pop these tubes on. And those tubes are then what's going to get sent. These all have a number. So these come with the number, and they take the number and they put it on every bag and every tube. so that your donor number, everything has it on it, so we know whose is whose. Those tubes get sent off for testing, and we'll talk about what all it gets here. But it's all done on a closed system, so the blood comes in, that's a separate closed system they're drawing. Once it's in this bag, all these other bags are attached. We'll talk about that when we get to processing. The blood then gets cooled down to room temperature, because when it comes out, it's warm. You guys have all felt that, right? And then it gets sent to the donor center for processing into its component parts. So it gets sent locally to the Badger Region Red Cross. Now, they do have these automated donations where blood gets collected by a machine, and what happens is it gets collected, separated into components, they keep what they want to keep, and they return the rest. So this is what people use when they're donating 2 units of red cells at the same time when they do a double donation. The requirements for a double donation are a little bit different. Their hematocrit has to be a little higher, things like that. But it goes in and they pull off the red cells and they return the plasma and platelets back to the person. It can take a little bit longer, but sometimes you can do up to 3 components at one time. So when that happens, you can't come in every 8 weeks, it's every 16 weeks, for example. So it takes a little bit longer, but they ask you to come in less often. So if your hematocrit is okay enough, it's sometimes not a bad way of doing it. Post-donation, they're gonna bandage your arm all up. There's gonna be a bandage on the inside and a bandage on the outside, and it's like after, you can take one off after like 30 minutes and the other one off after a couple hours. Instructed not to do any heavy lifting or drink any alcohol because you're down a unit of blood, and alcohol is gonna hit you a little bit faster. You know, one of my favorite things, even in phlebotomy, is, you tell them, don't lift anything heavy for that for a few minutes, and then what they do, the women pick up that heavy old purse, with the arm. But we don't want to, because when you do that, think about it, just like we're going to phlebotomy, you're going to pop that platelet plug and you're going to start bleeding. So we ask you not to use that arm for a little bit. You have to spend at least 15 minutes in the refreshment area. One of the things I have found, people are fine until they get to that refreshment area and then they've passed out. I've had several former students pass out at that point, which I've always found interesting. It's like you think they pass out when the meal is going in or going out. Nope, it's at the refreshment area. That's why they would spend 15 minutes there. You have to drink a glass of water, and then they'll give you juices or whatever else you want. There's cookies. Depending on where you go, if you ever want to donate and have an opportunity to go to a church donation, churches have the best treats. Because the church ladies bring like their special bars and cupcakes and, So if you're ever looking to donate, a local church is doing it. Sign up for that one. Encourage you in the next 24 hours to drink a lot of fluids. Hydrate yourself again, because we just took out a little bit, right? And I always joke, I always tell my daughter, whenever she's not feeling well, first thing I ask, have you drank any water today? Have you drank enough water today? You guys all hear that from your parents, right? But at this point, you probably kind of realize why. Think about urinalysis, things like this. Water is so important, and so we want you to hydrate. And especially after something like this. If you're not feeling well, hydrate. Are you laughing because you tell your kids that?
Oh, I told them to do that yesterday.
Told them to do that yesterday? Okay, yeah. It's true though, we forget. Especially when we were dealing with those masks, I always felt so dehydrated when I had a mask on all the time and couldn't carry my water with me everywhere. So goes back to what your mom always told you, have to drink your water today. Over the next 24 hours, drink extra fluids, rehydrate yourself. The liquid portion of your blood is going to be replaced within 24 hours. Your kidneys, we all know how they work, right? They're going to reabsorb any water. You'll pee a little bit less if you're not drinking enough water. But you'll get rehydrated. The red cells take a little longer to replace, and that's why you can't donate for another 8 weeks. How long does the red cell live from the time it starts to the end?
About 3 months.
About 3 months, 120 days, right? So, you got to kind of remember how long it takes to get them kind of back up. 8 weeks, they allow you to redonate. Because when you donate, some of those cells are day 1 of their life cycle. Some of those cells are on their 120th day of their life cycle, right? So you can donate then for 8 weeks. So testing, we're going to take that donor blood that we collected in those separate tubes and it's going to get tested. Testing is only done at a few sites. Nationwide, it gets centrally located. It's actually easier to batch them and do them faster. Madison sends blood samples to Detroit for typing and infectious disease testing. Excuse me. Most of this gets done by automated methods, some of it even gets batched. So we're gonna do ABO typing. Even if you've been in 100 times donating before and you're on your 10 gallons or whatever it is, we're still going to anti-A, anti-B, anti-AB, because we're looking for those AXs, right? So Red Cross always does A cell B. A1 and B cells, we might look for A2 cells to see if anything's going on. If there's any typing discrepancies, they're gonna resolve them. Depending on the typing discrepancy, it may not be the one that a unit that they send to a hospital. Because if there's a typing issue, when it gets to the hospital, they're gonna have trouble again. So they wanna make sure they don't cause headaches for hospitals. RH, if they're RH negative, they're gonna weak D type them. Remember, the only 2 times we weak D, donors and babies. Because we don't wanna cause reactions. We want to know that these D negatives are true D negatives. They're gonna do a DAT. Make sure the blood we're giving isn't already pre-coded, right? We wanna make sure it's okay. We're gonna do an antibody screen. They take 8 to 10 donors, they pool them together and then test them. If that pool is positive, then they'll test each one individually within that pool. But most of the time, antibody screens are negative. You know, who's positive? Possibly multiparous moms, multi-donor, multi-transfused people. You know, that's really gonna be it. Most people are screen negative. 99% of the blood you get through the lab is going to go type screen, send it out, no problems. So because of this, we can actually, when we pool this, we can get a lot more done more efficiently.
When you say pooled, do you literally mean like they add all the blood together?
Yep. They put X amount of each blood into one tube and they screen it.
If it does come out positive, do you have to test all of them separately?
Yes. Yes. So if it does come up positive, we pull them all separately. But if you think about how this gets done, let's say I've got 1,000 units to test, and I do pools of 10. Okay, I'm going to change to 100. I'm going to change to 100 because I don't want to draw 1,000 circles out. If I have 100 units to test, I'm going to do pools of 10, I have to run 10. Most of the time, they're all going to be negative, and I'm gone. If one of these needs done, now that gets another 10, right? Because it was a pool of 10. So now I'm still only running 20 samples to find that positive, and let's say it's that guy right there. So you can see how it's a lot more efficient. We don't do this on recipients, right? Because we want to make sure if we have a recipient that even has a little, we catch it. If a donor has just a little, it's probably not going to show up. It's not going to cause any problem. If we find the one that's positive, we'll identify the antibody. And then what we'll do is when we separate these units out, I'll talk about processing here in a minute, that plasma won't get used. And then the cells will get, could get used, but it'll get labeled that the plasma had whatever in it to make sure that, you know, people are aware of it. There could be a little bit of transient antibody. There's not gonna be a lot of plasma in it, but there's gonna be some, right? But it's just like giving O platelets to an A. It's got a little bit of anti-A, but it's gonna be self-limiting. That's kind of what they're looking at. Special antigen typing. Usually we only test donors for ABO-RH. However, as time permits, depending on how busy you are, they're gonna take group O donors and they're gonna start typing for some of those higher frequency antigens. Remember we talked about the rare donor program? This is how they do it. Remember I showed you guys the card, the rare donor card with like all this negative antigens? That's what they do. So we're gonna look at Duffy, kids, CC, little e, S and S, as resources allow. Because we want this for O because anybody can get O. So I can give type O blood that's negative for whatever to these patients. Donor centers also like to have an inventory of antigen negative blood on hand, so that if they do get a call from a hospital that, you know, somebody has an anti-big S, they can immediately send some O blood big S negative to the hospital. So it's already pre-antigen type, pre-labeled in the fridge, ready to grab and send out. If they don't have it on hand, all of a sudden they're scrambling, starting to type all their units, and now we've got a patient waiting somewhere. So they like to hang on to it and know. They also, once they do these donors, like when my husband's blood comes in, it gets tagged and put on the shelf because he's a rare donor. So it sits there, so they know. I mean, his is actually pre-labeled. They know when his comes in, it gets tagged to be a match. So infectious disease testing, we're gonna look for hepatitis B, C, HIV, HTLV 1 and 2, syphilis, West Nile, Chagas. Chagas has only been since January 2007. They only get one per lifetime. So the first time you donate, you'll get that one done. Babesia, that was a new one a couple years ago. They started testing for Babesia. Might be tested for CMV, primarily for babies. We want CMV negative blood, not CMV safe. But a lot of times the blood is CMV untested. But since we know it gets transferred in white cells, if you put it through a filter, or you irradiate it, destroy those red cells, or white cells, it's going to be reduced. They do nucleic acid testing these days, so it's a lot faster, pools of 6 or 16. They actually look for the triplets assay, it's HCV, HIV, RNA, and HBV DNA. They can use nucleic acid testing for West Nile, Babesia in high-risk states. In Puerto Rico, the newish testing, it's not as new anymore, Zika. Nucleic acid and these molecular test methods have really, really changed how we look at medicine. I was talking to a bunch of high school students on Friday, and we were talking about molecular and how molecular has advanced so much in the last 5 years. Our labs advanced more in 5 years than it had the previous 30, because we can really pinpoint and look for these specific diseases. So every time I do this, even if I reveal this today, it'd be different tomorrow because we're getting better and faster testing. So information about risk of infection. So people used to always be afraid, I don't want to get any blood because I might get AIDS. That was a big problem a few years ago, or they really pushed for directed donations, where they find a buddy of theirs to donate. But the actual risk, in 1970, the risk was of hepatitis, 1 in 100 units had it. We actually had a bunch of kids in the mid to late 70s that all got hepatitis C, because we didn't even test for hepatitis C. We didn't know it existed. And they were getting, hemophiliacs in particular, getting blood products, ended up all with hepatitis C later in life. 2000 on, they say 1 in 100,000, but in reality it's even less than that. But when you're looking at the numbers, you can't get the numbers farther extrapolate. It's a numbers game, right? But out of every 100,000 units, it's less than 1. It's actually way less than 1. AIDS, 1970, we didn't test, we didn't know, didn't exist. 2000 plus, 1 in 675,000. At that point, this is many, many years old. But if you actually do the numbers, this was probably put together, this slide was probably done 10 years ago. There were only 6 documented cases since 2000. So if you think of how many units of blood and how, it ends up being way less than that 1 in 675,000, but again, you can't get the numbers down that far. Parasites in the US, 1 in a million. We just don't see the type of parasitic infection here.
Do you know when the test for HIV was first invented? Obviously they've
updated it a lot. It was in the late 80s, early 90s, I think, is when it kind of started, but it was really hard. Wasn't a very good test, and that's why a lot of the rules got put into the blood donation rules, because the testing was poor. And the test we tested for, you wouldn't find it for 6 months after they had it. So if they donated for 6 months, then turned up positive, they could have been transmitting it that whole time. So it's gotten a lot better. Unfortunately, our rules for blood donation haven't.
They have.
They've gotten a little better.
Very recently.
The 3-month rule? Yeah, but still.
But it's about to change. It's in the process of being updated from the 3-month rule.
We're fighting it hard. There's a whole bunch of people out there fighting for that, for the change, you know what I'm saying, not fighting against it.
There's a
Um,
proposal being written up.
Good.
It's in the
Is
process.
this Carlo?
Yeah, actually.
I love that guy.
Hey,
He's gonna move this, he's gonna move us. He's gonna get us moving. There's a study done in Brazil back in, oh man, it was in my journal, 2007, 8, 9, something like that. And the study proved that it didn't matter who you had sex with. It matters how many sexual partners you have. Duh, right? And so Brazil changed the rules, and they kind of like, they did this risk analysis, and it was, I don't remember what the numbers they came up with at that time, but if you had had more than X number of partners in X period of time, you were deferred, which made way more sense than the homosexual man who's been married to the same man for 20 years not being able to donate.
And that's what they're changing it to is, sexual encounters as opposed to.
Good. Good.
It's like if you,
I am gonna have to totally rewrite this now, but that's good. Yeah, it makes sense. 2007-ish, this journal article came out. I used to share it, but it became such an old journal article, I quit. But it came out then that this was how it needed to be. And I mean, that's 16 years ago, and we're still stuck.
Yeah, I mean, it's not like, I mean, obviously it doesn't get reported. It's not like, have you been in a homosexual relationship, like donating blood? A lot of times I feel like it doesn't get answered quite as truthfully.
Well, and that's when we get into directed donors, I'll tell you about that, because they've actually gotten away from directed donors because, man, my baby needs blood and I need blood, so, you know, oh, you're an A, will you go donate it, it will put my baby's name on it, and, well, you either out somebody as not being able to donate, or they lie. You know, and so, and then that blood goes into the general blood supply, and it's not as safe. So a lot of places have gotten away from it. Most places have now. So we'll talk about that in the next slide or two. So autologous donation, they've actually, a lot of places have gotten away from that. We used to go in, like knees in particular, hips, joints, you go in ahead of time, you donate your own blood for you, and they put your name on it. Ortho, neuro, OB-GYN, plastic surgeries, things like that. You need a doctor's order, so you can't just go in and do it. You have to have a doctor's order for it. Doesn't have to meet all the regular requirements of a normal donor when you're donating for yourself. It's considered safer for the recipient because you're only getting your antigens, right? So you're not going to develop antibodies. And it won't transmit any infectious diseases you don't already have. So the infectious disease transmission, though, is like small. Some of the exceptions for autologous donors, they can be younger or lower weight. They just collect less blood. So, you know, a kid can donate for themselves. They can donate every 3 days. We recommend 1 week because we don't want you starting out low. Minimum hematocrit is only a 33 versus 38. You only have to pass the HIV and the HTLV, and that is because it has to do with transport. Because where they collect it and where they give it, it transports, so they want that passed. Autologous blood can only be transfused back to you. If it doesn't get used, it gets thrown away. One of the problems they have with this, there's a couple problems, but one, surgeons would say, oh, it's their own blood, it's fine, just go ahead and give them the unit. So they order the blood, whether they really need it or not, to fill them back up. The big problem is, you are starting this procedure or whatever, a unit low. You know, if you're going in for a surgery, you want to be at like your peak health. And you're starting a little low anyway. And what's that going to do to your healing and everything else? So they actually have realized over time, it's actually better not to take it, and you probably won't need it at the end, and you won't get the sodium citrate and all the other additives and preservatives and things like that. Intraoperative autologous collections, that's a little bit different. When you're dealing with heavy bloody surgeries, they'll actually collect the blood and reinfuse it into you. So thoracic surgery especially has to be from a clean site, but they'll collect it and reinfuse. Like, so if you're bleeding out, they'll be giving you your own blood intraoperatively. If it's not given back to you during surgery, you can give it within 24 hours. So, you know, it might start kind of back, they may take you back to ICU or back to the room with it. Within 24 hours, it has to go into you. Very common in thoracic surgeries. Lung surgeries are very bloody. So it's commonly done in thoracic surgeries. This is also known as shed blood because the blood is being shed and then reflected. So this is, I always thought this one's so funny. Not exactly what is meant by shed blood. So directed donations. This is what I was talking about a minute ago where, hey, I don't feel safe with the general blood supply. Will you give blood for me? They recruit them, they donate specifically. Again, it's not necessarily safer. They still have to pass all the things because if they don't get used by that patient, they go into the general supply to be used by another patient. But patients tend to lie, or donors tend to lie, because you find out whose blood is in the blood bank for you. And if I ask, John and Jim to donate for me, and Jim's isn't there, I have to find, well, why, Jim, why is your blood there? Why is your blood there? Well, he either can't donate, knows it, or something turned positive, and now I know he's got something, right? So it's not a good deal. Must be irradiated if it's from a blood relative to prevent some blood graft versus host. Recently on the Facebook page, does anybody follow the MLS Facebook page, MLS group? Okay. MLS, MLT, ASCP, I don't even know what all it is, but there was a case where somebody was really, really angry and upset because their daughters had, I don't remember, some type of blood disorder, and they had to go in and get blood transfusions every 6 to 8 weeks. And so they had a group of people that would do these directed donations. Well, the insurance quit covering it, so they were paid for it out of pocket for a while because the insurance recognizes that it's not worth it. It costs more to do a directed donation than a regular blood. And then the blood center quit doing it because, it's not as safe. Well, they were throwing a fit. They don't understand. They're not in the world. They're not in the lab world. They don't understand why it's not as safe. To them, it felt safer. So they went on the Facebook group with this huge rant about, I need everybody to call the blood center, and we're all like, no, it's not. Trying to explain to her and calm her down and let her know the blood supply is safe. She thinks that her girls aren't going to get the right blood. Well, hopefully right now you guys all realize they're still going to get the right blood if it's not going to be from a particular person. Directed donations, mothers are discouraged from donating to their children because you may have developed antibodies during pregnancy. Husbands are discouraged from donating to their wives of childbearing age because we don't want to stimulate antibody formation for HDFA at a later point. So, when you do donate, when you get an email, it was donation on its way to changing lives. This is one a friend of mine sent me. And it says, your blood donation was sent to Rush University Medical Center in Chicago, Illinois to help a patient in need. So it kind of tells you, it's kind of cool. It tells you where your blood's going, where it was used. A lot of our blood in the Badger region does go to Chicago. We do support Chicago's blood supply. They need a lot more of it. They have a lot more hospitals. We also support Milwaukee, although Milwaukee also has the Milwaukee Blood Center, which actually, it was Milwaukee Blood Center, then it was Wisconsin Blood Center, and then it became Versiti or something like that. So it's a different blood center. They've changed names and merged a few times. So here's another comic, Foxtrot. Any questions?